This microslide represents liver. Staining is hematoxylinosin. Name of the slide is Nutmeg liver. This pathological condition occurs due to chronic venous congestion or passive hyperemia that relates to hemodynamic disturbances. The causes for these disorders could be different. These are chronic congestive heart failure, namely right ventricular heart failure, or could be local disturbances of venous outflow from the liver by the hepatic veins. For example, due to thrombosis of the hepatic veins known as Budd-Chiari syndrome. The pathogenesis of the formation of nutmeg liver includes so-called parenchymal capillary block, which includes the following. Firstly, the damage of the venous outflow from the liver due to the general or local hemodynamic disturbances. Then it leads to increased hydrostatic pressure as well as increased microvascular permeability. This leads to plasmaregia, edema of the interstitial space of the liver, and extravasation of blood cells. It leads to fibroblast activation, formation of collagen, as well as formation of the basement membrane of sinusoid capillaries, known as capillarization of sinusoids. Finally, it leads to fibrosis, damage of blood tissue exchange, and aggravation of hypoxia. At low magnification, liver has a heterogeneous structure, with distinct differences between two main parts, which are central lobular parts of the hepatic lobules and periportal zones or parts of the hepatic lobules. At high magnification, the following changes can be observed. Firstly, we can see dilation of the central veins of the hepatic lobules, as well as congestion of the vessels of the microcircular bed. So sinusoid capillaries look congested and full-blooded. There are pronounced necrobiotic changes of hepatocytes in central lobular zones of the hepatic lobules, means central lobular necrosis, along with focal hemorrhages and accumulation of hemosiderin. Finally, there are degenerative changes of hepatocytes at the periphery of the lobules, means at periportal zones of the hepatic lobules, in the form of intracellular fatty degeneration of hepatocytes. Also, some accumulation of brown color pigment can be seen. It can be hemosiderin accumulation at the cytoplasm of macrophages or Kupffer cells due to hemolysis, or it can be accumulation of lipidogenic pigment lipofuscin within the cytoplasm of hepatocytes due to severe hypoxia. These microscopic changes in the central lobular and periportal zones of the hepatic lobules are related to the appropriate macroscopic appearance of nutmeg liver. So, on the yellow background due to fatty degeneration, there are spots of dark red color due to hemorrhages, hemosiderin accumulation, and central lobular necrosis. The outcome of such condition is so-called nutmeg cirrhosis, which happens due to progressive growth of the fibrous connective tissue. The lung tissue can be seen at this slide. Stain is hematoxylinosin. Name of the slide is brown induration of the lungs, or chronic venous congestion of the lungs. This pathological condition occurs due to chronic venous congestion or passive hyperemia that relates to hemodynamic disturbances. The cause of the brown induration of the lungs is chronic heart failure by left ventricular type. For example, due to post-infarction cardiosclerosis or valvular heart disease with valence of the venous outflow from the lungs. The pathogenesis of this disorder has similar mechanisms to chronic venous congestion in the liver, with the same outcome into pronounced pulmonary fibrosis. The main microscopic changes include accumulation of brown color pigment, namely hemosiderin, within the cytoplasm of the specialized cells known as siderophages, as well as thickening of the interalveolar septa due to hyperemia and fibrosis. We can see siderophages, and these cells are also known as heart failure cells because they appear as a result of left side heart failure. Also, some alveoli are filled with edematous fluid. We can see thickening of the interalveolar septa, growing of the connective tissue fibrosis, as well as presence of some blood cells, RBCs, within the lumen of the alveoli due to increased vascular permeability. To confirm accumulation of hemosiderin, a special reaction or staining can be used. Such reaction is known as Pearl's reaction or Prussian blue reaction. It stains iron-containing pigments, including hemosiderin, in bright blue-green color. The outcome of this condition, same as in case of nutmeg liver, is pulmonary fibrosis, with respiratory failure and subsequently with mixed pulmonary and heart failure due to fibrosis of pulmonary vessels, pulmonary hypertension, leading to the pulmonary heart, also known as cor pulmonale, and finally, congestive heart failure. On this slide, we can see an artery. Stain is hematoxylin and niacin. Name of the slide is Organization, Recanalization and Vascularization of the Thrombus. This slide represents a relatively favorable outcome of thrombosis, where the thrombus is firstly replaced by the connective tissue, so its organization happens, with subsequent formation of gaps, so partial recanalization of the lumen of the vessel can be seen, and finally endothelium grows into these gaps, so vascularization occurs. Finally, it leads to partial recovery of the blood flow. On this slide, we can see wall of the vessel and its lumen, filled with fibrous connective tissue. This points to the organization. At high magnification, gaps in the lumen of organized thrombus can be seen, indicating the recanalization of the thrombus. Finally, these gaps are lined with endothelium, indicating that the vascularization of the thrombus happens. Also, we can see brown pigment. This brown pigment is hemosiderin, which appeared as a result of red blood cell hemolysis at the time of the formation of thrombus and its subsequent organization. It is a lung tissue presented on this slide. Staining is hematoxylin and niacin. Name of the slide is Croupous pneumonia with abscess formation. This condition illustrates two types of exudative inflammation. Firstly, it is a Croupous inflammation, which is a kind of fibrinous inflammation and which is characterized by the predominance of fibrin strands in exudate that are loosely associated with underlying tissues. Secondly, it is a purulent inflammation, in particular limited purulent inflammation known as abscess. Purulent inflammation is characterized mainly by the predominance of neutrophils in the exudate. The slide at low magnification appears non-uniform and can be divided into the three main zones. The first zone is a zone of relatively intact lung tissue with alveoli. Some edematous changes can be seen there, as well as some areas of black color pigment can be seen due to the accumulation of coal dust in the interstitium of the lungs. The second zone is a zone of Croupous inflammation. In particular, we are talking about so-called lobar pneumonia in a stage of gray hepatization. Alveoli are filled with loose exudate and thin and chaotically arranged eosinophilic fibrin strands, with a relatively small number of cells represented by neutrophils and tissue macrophages. The third zone is a zone of limited purulent inflammation and destruction of the lung tissue with the formation of cavity filled with the purulent exudate, which is known as an abscess. The main component of exudate is neutrophils. Generally, this case refers to lobar pneumonia complicated by the formation of the limited purulent inflammation known as an abscess. This slide is a transverse histological section of the appendix or vermiform process. Staining is hematoxylinosine. Name of the slide is Phlegmonous ulcerative appendicitis. This slide represents an inflammation of the appendix and illustrates one more kind of purulent inflammation. In particular, this kind of inflammation is known as a phlegmonous inflammation. Generally, phlegmon is a diffuse purulent inflammation which doesn't have clear boundaries and which can occur not only in subcutaneous adipose tissue or spaces between muscular fascias, but also in the wall of the hollow organs such as the appendix. As with any other form of suppurative inflammation, a hallmark or main criteria is the predominance of polymorphonuclear leukocytes or neutrophils in exudate. At low magnification, wall of the appendix and its lumen can be seen. Lumen is partially filled with a purulent exudate. A characteristic feature of the phlegmon of the appendix is damage of all the layers of the organ. Means damage of the mucosa, submucosa, muscular layer, as well as serosa. At higher magnification, the most pronounced neutrophilic infiltration can be observed in the mucosa and the submucosa of the vermiform process or appendix. So here we can see infiltration by neutrophils as well as epithelial destruction. Along with this, it should be noted that appendix submucosa normally contains lymphoid follicles, and these follicles should be distinguished from neutrophilic infiltration. Due to the presence of destruction of the epithelium layer, this appendicitis is called as an ulcerative. Due to the phlegmonous nature of inflammation, neutrophilic infiltration is also present in the muscular layer as well as in serous layer. The most common complication of this process is loss of the integrity of the appendix wall and transition of the inflammation into the peritoneum with peritonitis and generalization of purulent inflammation with formation of abscesses in the liver or development of septic conditions. This slide is a histological section of the lung tissue. Staining is hematoxylin and azine. Name of the slide is wall of the tuberculosis cavity or cavern. This preparation illustrates specific proliferative granulomatous inflammation, particularly formation of the tuberculoma with subsequent degradation of the caseous necrosis in the center and formation of the cavity known as cavern. At low magnification, the wall of the tuberculosis cavity has 3 layers. An inner layer is formed by necrotic, homogeneous, non-cellular dry masses, which is represented by the caseous necrosis. The middle layer contains the specific tuberculosis granulation tissue with very pronounced lymphohistiocytic infiltration as well as specific multinucleated Langhans cells. Finally, the outer layer, considering the chronic nature of inflammation, is a fibrous connective tissue or fibrosis. At another part of this slide, another structure can be seen. Here is formation known as tuberculoma. It also has layers and consists of caseous necrosis in the center, as well as layer of the fibrous tissue around with a lot of lymphocytes, macrophages, epithelioid cells, as well as giant multinucleated Langhans cells. These cells may contain 10 to 15 nuclei located mostly at the periphery of the cells in a horseshoe manner. In addition, there are a small number of blood vessels in the zone of specific inflammation, which is one of the key differences between the microscopical structure of tuberculoma in tuberculosis and gumma in syphilis. This slide is a histological section of the prostate gland. Staining is hematoxylin and azine. Name of the slide is benign prostatic hyperplasia. These slides illustrate the process relating to the compensatory and adaptive reactions, namely hyperplasia. According to definition, hyperplasia is a process characterized by the increase in volume of an organ or tissue by increasing the number of cells. According to classification, there are reactive or protecting hyperplasia, hormonal hyperplasia, and compensatory hyperplasia. In case of prostate gland, hyperplasia process is most often caused by the hormonal disorders. At low magnification, the prostate gland is represented by the 2 major components, namely glandular component of the prostate gland as well as fibromuscular or stromal component of the prostate gland. Hyperplastic process in the prostate gland involves proliferation both glandular and stromal component. at high magnification, glandular epithelium forms a double layer epithelium, which inner part is formed by the high columnar epithelium, and the outer layer is formed by the flattened epithelial cells. Lumen of the glands often contains the so-called amyloid bodies, which are mostly formed by hyaline protein and the squamate epithelial cells, so amyloid bodies are not related to amyloidosis despite such name. Also, there is a proliferation of hyperplastic fibromuscular stroma of the prostate gland, and it may contain some features of chronic nonspecific inflammation in the form of lymphohistiocytic infiltration. The most important complications and outcome of this condition are related to the violation of urine outflow, ejaculatory function, as well as possible malignancy process.